My name is Dominic Power. I'm a consultant hand and peripheral nerve surgeon and one of the editors for Orthoracal Hand, Wrist and Peripheral Nerve. This short talk is about nerve tumours. Nerve tumours are fortunately uncommon. Most present incidental findings on scans for other reasons, but occasionally in superficially placed nerves, particularly when a benign nerve tumour grows or increases in size, it may be palpable, and if it's in an area of contact, it can be a source of irritation, producing pain and neuropathic features or tingling when it's knocked. The majority of nerve tumours that we see are benign, and these are nerve sheath tumours, so not tumours of the nerve cell. Typically, the common nerve tumours that we see are schwannomas or neurofibromas. The indication for surgery is if they're painful, they're increasing in size, there's diagnostic uncertainty, if there's recurrence at a site of previous resection, or if there is sensory or motor deficit. Asymptomatic incidental findings with typical scan imaging suggestive of a schwannoma can simply be monitored, and this can be with clinical surveillance, with or without MRI surveillance. The indication for a biopsy is an important discussion point in peripheral nerve surgery. In order to have a diagnostic biopsy, it's extremely important to diagnose a tumour and also to take tissue away from normal fascicles so that the relationship between the tumour and the fascicles can be seen by the histopathologist. The consequences of this are causing a nerve injury with a source of pain and also functional loss, both in terms of sensation and potentially movement. So typically my diagnostic algorithm for someone who has a typical schwannoma or neurofibroma with a benign appearance on MRI scan and no red flag features would be to undertake an excision biopsy where indicated. In situations where the imaging is less certain, there's a tumour mass that's increasing in size, that's painful and associated with significant deficits, these cases can be rare malignant peripheral nerve sheath tumours. Now, these are exceedingly uncommon, but in all suspicious cases, an open biopsy or a true cut biopsy of the nerve should be planned in advance of the surgical resection. The problem with this is if the biopsy becomes evidence that it is a benign tumour, resecting the tumour from within the nerve can be more challenging because of scar. However, the treatment for a malignant tumour is an aggressive one with resection of the nerve with normal tissue above and below and excision of adjacent structures where necessary, sometimes even compartmental excision. So my approach to peripheral nerve sheath tumours is simple. Benign tumours can be imaged. If they're asymptomatic, they can be monitored clinically. If they're symptomatic, increasing in size or associated with deteriorating function, then I would plan an excision biopsy. In cases where the imaging is less certain, these should be imaged and discussed within a sarcoma MDT setting. Additional imaging such as MR spectroscopy can sometimes show areas of enhanced activity within the tumour, and a planned biopsy prior to surgical excision is necessary.